Thank you very much. I appreciate the opportunity to contribute to this instructional course symposium by presenting information on vitreous, hyalocytes, anomalous PVD, and vitreoschisis. There is a multi-laminar structure to the posterior vitreous cortex that is demonstrated on these images of immunohistochemistry as well as OCT. Splitting between the lamellae of the posterior vitreous cortex can result in separation of the vitreous away from the retina, but persistent adhesion of the outer lamellae of the posterior vitreous cortex to the retina. We know that there are age-related changes in the human vitreous body that are demonstrated in the upper three images on this slide. In youth, the collagen fibrils of vitreous are separated, and that minimizes light scattering, inducing transparency. By middle age, there's cross-linking and aggregation of the collagen fibrils into visible fibers that have an antero-posterior orientation coursing from the vitreous base to the posterior vitreous cortex. By old age, these fibers become thickened and tortuous and are associated with pockets of liquefied vitreous. This process destabilizes the vitreous body and induces collapse. If there is sufficient dehiscence and weakening at the vitreoretinal interface, the separation is innocuous and can be imaged by photography, as shown in the center photograph below, and sometimes by OCT, as shown on the left. However, recent studies have demonstrated that spectral domain OCT only has a predictive value of 53% when compared to intraoperative findings. Thus, we typically employ B-scan ultrasonography, as shown in the lower right image, to diagnose PVD clinically. Anomalous PVD results when there's liquefaction of the gel vitreous without sufficient dehiscence at the vitreoretinal interface to allow a clean separation. Traction in the periphery can tear the retina and induce retinal detachment. Untoward effects upon the posterior vitreous cortex can result in vitreoschisis because of splitting between the lamellae of the posterior vitreous, and that leaves a membrane attached to the retina. When hyalocytes are present within that membrane, posteriorly they can be tangential traction, inducing a macular pucker, but peripherally they can be tangential as well as axial traction, contributing to the development of PVR, as pointed out to us by Koen van Overdam. Vitreoschisis was first described by ultrasonography in patients with proliferative diabetic vitreoretinopathy. You can see ultrasound imaging of vitreoschisis in the three images to the left. When there is vitreous hemorrhage into a vitreoschisis cavity, the red blood cells can settle to the bottom of the cavity and create a boat-shaped appearance, such as shown in the fundus photograph in the center. Vitreoschisis can also occur in patients with diabetic macular edema, as shown in the OCT images on the right. There can also be posterior vitreoschisis in patients with age-related macular degeneration. But nowhere is vitreoschisis more important than in the pathogenesis of macular pucker. Studies have shown that 53% of eyes with a macular pucker will have vitreoschisis as detected by spectral domain OCT. I predict that swept source OCT and other imaging modalities may show that the true prevalence of vitreoschisis in macular pucker is higher. The patient whose OCT image is shown in the upper left had surgery by me to peel the membrane, and I analyzed the specimen histopathologically, and you can see the results on the right. This demonstrates a split in the posterior vitreous cortex with hyalocytes embedded inside this tissue. Dark field slit microscopy is shown in the upper left-hand image in the vitreous body of a middle-aged man, and you can see hyalocytes embedded in the posterior vitreous cortex. I performed phase contrast microscopy on specimens such as this, and the results are shown in the middle photograph below. The hyalocytes are distributed in a monolayer, which we used to think was 50 to 75 microns anterior to the retina, but is probably not true. insofar as recent studies have demonstrated they can be distributed anywhere from 10 microns to a few hundred microns anterior to the ILM. We'll get more information as swept source OCT analysis is increased, such as shown in the lower left-hand panel. The transmission electron micrograph to the right demonstrates that there is embedding of a human hyalocyte in the posterior vitreous cortex, as evidenced by the collagen fibrils present both anterior and posterior to the hyalocyte. I'm excited about the development of adaptive optics in OCT and their application to imaging the vitreoretinal interface, where cells have been identified. To date, these cells are being called macrophage-like cells of the retina, but I predict that future studies will show that these cells are not within the retina, but they are anterior to the retina, embedded within the posterior vitreous cortex, and that they are indeed hyalocytes. Peripheral vitreoschisis can promote PVR by the action of hyalocytes. And the mechanism is as follows. Vitreoschisis that splits more than 100 microns anterior from the ILM will leave hyalocytes attached to the ILM. These will then recruit cells from the retina, primarily glial cells, and from the blood, primarily monocytes, resulting in a hypercellular membrane that is highly contractile and contributes to the pathophysiology of PVR. Vitreoschisis posterior to the hyalocytes results in a hypocellular membrane and no PVR. So in conclusion, I congratulate Kern van Overdam and others for looking at vitreous rather than just through it and understanding the role of vitreoschisis and hyalocytes in PVR. Thank you very much for your attention.